Let's talk about ALL. Okay, ALL, similar to AML, has a French-American British classification. And it was classified L1 to L3. L1 is again very immature, small uniform cells. L2, large varied cells. And L3, large varied cells with vacuoles. Really, this classification we don't use anymore, but we use the WHO classification similar to AML, and this gets classified as the following. Acute lymphoblastic leukemia lymphoma, either precursor B lymphoblastic leukemia or precursor T lymphoblastic leukemia, so it looks again at the cell of origin with flow cytometry. For precursor B lymphoblastic leukemia, it looks at cytogenetic abnormalities, in particular the Philadelphia chromosome 922. Okay, so similar to CML, you can have a translocation between 9 and 22, and that is very important in determining treatment. Lastly, a more mature form of leukemia, in contrast to your precursor leukemia, is Burkitt's lymphoma or leukemia. Okay, so here's a table with the WHO classes, the FAB classes, and certain markers that actually help you sort out whether this is precursor, B, T, or mature leukemia. To note is that in all precursor leukemias, TDT is positive in precursors, but negative in mature or Burkitt's leukemia. And the reason is that TDT is heavily involved in the recombination of immunoglobulins, so it's mainly in early forms of leukemic cells. Then we have B markers, and you know the B markers already because you have listened in the flow cytometry part, 9, 22, and 79. It's going to be positive in precursor B cell, but negative in the T cell part, as well as T cell markers, CD3 and CD7, which are going to be positive in the precursor T cell part. Okay? Because B cells make antibodies, you will find cytoplasmic or surface antibodies in B cells, but not T cells. Okay? And whether they're in the cytoplasm or on the surface tells you how mature those cells are. While they're still getting made, those antibodies, they're in the cytoplasm. Okay, and they belong to more immature cells. When they're made, they get presented on the surface and they characterize more mature cells. So just to illustrate that again, this is an immature cell. For example, this is a precursor B leukemia. We will see they have B markers here. CD19, for example, or 22, or 79. And you can tell this is a B cell lineage leukemia. They have cytoplasmic IgGs that are in the cytoplasm and get produced there, and they have TDT that's important for recombination of antibodies. And if you go to a mature or Burkitt's leukemia, what you still have is B cell markers, but the TDT is gone, okay, because you don't have to make those antibodies anymore, and the cytoplasmic antibody actually went up to the surface. Okay, so this is how you actually can tell whether you have an immature or mature ALL. How does ALL get treated? Similar to AML, again, there is a good prognosis subtype and a bad prognosis subtype. Okay, good prognosis subtype is patients that are relatively young. Okay, patients who are 15, 39 years old are normally patients with a relatively good prognosis. Older patients, adult ALL patients, normally a poor prognosis. The therapy is relatively similar, again, with the induction therapy and parts of the consolidation therapy, okay? They all get a therapy combining multiple different chemotherapeutic agents. The patients that are relatively young get the chemotherapy that's used for pediatric regimens, and adult patients get also multiple chemotherapy, but it is a little bit different. Often they get a chemotherapy called hyper-CVAD. Okay, and you really don't need to know everything about hyper-CVAD. Important is just that it has two different courses, A and B. It's hyperfractionated, okay, which means smaller doses more frequently to limit side effects. And it's a combination of all kinds of chemotherapies, okay, cyclophosphamide, vincristine, doxorubicin, dexamethasone, methotrexate, and cytarabine, okay, so multiple different chemotherapies. Both younger patients, ALL, as well as older patients, get a consolidation chemotherapy. And then, again, it's a question, do they need a stem cell transplant? Young patients need them only if they are higher risk patients. Older patients will always get a stem cell transplant if they can tolerate it. Okay? And then, most importantly, they need maintenance chemotherapy and CNS prophylaxis. Okay? ALL loves to go to the CNS, and they need intrathecal chemotherapy. And they get that normally with daily 6 MP, weekly methotrexate for CNS prophylaxis, as well as sometimes vincristine and prednisone. And that goes on for 2 to 3 years. So they need chemotherapy for quite a long time. Again, center here to remember is they need CNS prophylaxis. Okay? 80%, that's a huge number of children with ALL who had a complete remission, relapsed with leukemic meningitis before we knew CNS prophylaxis. Okay, so this is key. And what we can use is radiotherapy or intrathecal chemotherapy with methotrexate, which I mentioned here. Lastly, I want to mention the specific genetic subtype of Philadelphia positive ALL. Always important to look for that because those patients actually get treated with TKIs, just as CML patients do. And lastly, let's talk about CML and CLL. Similar to AML and ALL, I want to kind of have you think about it in good prognosis and bad prognosis and kind of intermediate prognosis, okay? Your good prognosis are those patients with chronic phase. Remember, those are patients who have less than 10% blasts in the bone marrow. What they basically get is getting a TKI lifelong, okay? And the different TKIs, there's imatinib, nilotinib, and dasatinib. Normally, nilotinib and dasatinib, a patient is getting after developing certain resistant mutations against imatinib. If you are in the accelerated phase, 10 to 20% blast, you still get a TKI, but frequent monitoring to make sure you don't miss what's called a blastic phase, okay, with greater than 20% blasts, because this would be treated like AML and has a very poor prognosis, okay? So CML that converts to AML is a poor prognosis AML and goes for hematopoietic stem cell transplant if tolerated. CLL, similar 3 levels that you need to think about, okay? Good prognosis, bad prognosis, and kind of intermediate prognosis. They actually get staged in the RAI classification system. And RAI looks at findings on top of the CLL, okay? Meaning, do you have lymphocytosis? Is there lymphadenopathy? Is there hepatosplenomegaly? Or, and this puts you in a higher type of CLL, is there concurrent anemia and thrombocytopenia? So if you have anemia and thrombocytopenia, you're kind of in the intermediate risk group, which is a higher risk group. If you're in the low risk group, let's say you only have some lymphocytosis, some lymphadenopathy or hepatosplenomegaly, but no anemia and no thrombocytopenia, watchful waiting is enough. So those patients don't need to get chemotherapy because they have a very slow growing anemia. But let's say on top of lymphocytosis, you also have anemia and thrombocytopenia, then you normally go for chemotherapy. And classic chemotherapy here is FCR with fludarabine, cyclophosphamide, and rituximab, which is an antibody against CD20. Again, the very poor prognosis subtype is after it transformed into ALL. Keep in mind, it's 20% blasts is the definition of leukemia. Those patients get treated like ALL patients and again require a hematopoietic stem cell transplant because they're poor prognosis leukemia patients.